For a newly graduated surgical resident, one of the most interesting and perplexing question that many folks have to deal with, it's a surprisingly simple question. What should a full-time surgical job actually look like? For many of us, we simply just looked at our predecessors' job and modeled our own careers after them. And this meant typically ensuring that our schedules were jam-packed with clinical activities every day, likely because that's how we got paid. And that was without much consideration for the other aspects of our career, such as when do we recover from call or when do we do research, etc. At the beginning of March, the American College of Surgeons released a framework of standards of what they think is a reasonable expectation or reasonable expectations are for a surgeon's job. You can see the link to the paper in the show notes. The American College of Surgeons, or ACS, is one of the largest surgical organizations in North America. And this standard framework that they put out is really a statement on what they think is necessary to ensure that surgeons have a sustainable career. They put out standards for call coverage and requirements, for access to the OR, access to clinic, resource access, inpatient census. So how many patients should be a reasonable amount of patients to have on an inpatient census for surgeons, clinical support, and even fatigue mitigation. Dr. Patrick Murphy is a trauma and acute care surgeon at the Medical College of Wisconsin, and he's a previous guest on our show when we brought him on to talk about the work that he had done to try to define what a full-time FTE surgeon looks like. So he was actually the one who brought this framework to our attention, and we invited him on the Cold Steel podcast once again to talk about the implications of ACS putting out such a framework. So I want to preface this discussion by saying that I do think it is important for residents and medical students to realize that surgery and surgeons are sometimes still going to have to work under fatigue and duress. And that's just simply the nature of the specialty. It's impossible to create a call system currently where surgeons never have to work when they're tired or never have to work post-call. That's just simply not possible. If you think about a neurosurgeon, for example, it's for a variety of reasons, it's probably not possible to hire enough neurosurgeons such that they're never having to work post-call. And I think that's the reality, particularly in our publicly funded system in Canada. So I think that's an important disclaimer for our discussion that regardless of whether we think these expectations put out by the American College of Surgeons is reasonable or not, surgery is not for the faint-hearted, and it is a specialty in which you may have to work under duress or while you're tired. So I think it's important that we know that we have the fortitude to be able to stay calm under crisis and work even while fatigued. And having said all that, I think this framework from the ACS is a really important step in trying to make explicit what the expectations should be surrounding a surgical career. And a lot of this goes back to generational shifts, to culture shifts, and a lot of the ongoing work, I think, by many surgeons to try to make sure that surgeons have a long and fulfilling career. Towards the end of the podcast, Pat Murphy and I spent some time talking about some of the books we've both been reading by Cal Newport. Cal Newport is a scientist, a computer scientist at Georgetown University, and we've been obsessed with his books. Make sure to check out his books, Deep Work and Slow Productivity. He's written a bunch of books. His main thesis and his interests have been around the technology space and how our attention is being divided, but also around this idea that our careers should return to a more meaningful approach and a step away from this sort of pseudo productivity that has filled our lives and our careers, where we're just sending emails and thinking that we've done work during the day. I think his ideas have a lot of resonance in the surgical space. And I think one of the fundamental ideas I took from his work is this idea that we should really be intentional about what we want our careers to look like if we want to keep them meaningful. So we're really excited to bring you this podcast talking about the anatomy of expectations. What should a surgeon's job look like? We'd love to hear your thoughts. Send us an email at podcast.cgs@gmail.com or find us on X/Twitter. You can find all the links in the show notes.
Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Once again, I'd like to uh, thank Dr. Patrick Murphy for joining us on the Cold Steel podcast. It's an absolute pleasure to have him back on the show to talk about another really important addition to some of the topics and things that we discussed with Dr. Murphy on the last episode. And if folks haven't heard that episode, they really should go back and listen to it, because Dr. Murphy's really done some seminal work in trying to define. I don't want to do a bad job of paraphrasing this, but basically, what constitutes a surgeon's job? Which sounds like a simple thing to do, but is really quite difficult. So, Dr. Murphy actually brought this paper to my attention, which is a framework that was set out by the American College of Surgeons. So, if folks don't know what that is, so the American College of Surgeons is basically the biggest body of surgeons in certainly in the United States and in North America, and encompasses basically all the surgical specialties. They do a lot of governmental liaisons, and they set a lot of standards and things like that. But this paper that they put out, which we'll obviously put in the show notes, actually tried to set out standards for what should be expected for a surgeon in terms of their job. Could you talk a little bit about why you wanted to talk about this paper and sort of what interested you about this?
Well, what was interesting to me, there was, a few items. And again, as we discussed this, and I encourage you to go read this paper. And if you're short on time, just start on page 8. That's where all the kind of meat is. It not only suggests some framework about how and why surgeons might work the way they do, but it also suggests the infrastructure that is needed for a surgeon to be successful. And, just to take from the article some recommendations, a full-time clinical surgeon should be allocated a minimum of 2 full OR block days, 8 to 12 hours each per week. And before I go on, Amir, how many OR days a week do you have block time?
I have basically one OR day that's mine, and then one or like one assist day, and then sometimes a second OR day. So it's some usually about 1.5 OR days a week.
Is that pretty consistent across your group?
That's consistent in our group, and our group is very egalitarian um, with regards to that. But obviously that's very variable depending on where you work.
The other thing, mentioned here, somewhat relevant to my domain, call. Most surgeons across the country take call, and this framework suggests some call standards. And admittedly, they're not citing a lot of evidence here, but I think we all live this experience and probably have a innate understanding about what's reasonable. And admittedly, and maybe somewhat selfishly, they align with some of the work I've published. And we've published through, talking to acute care surgeons around the country for the last 5 years, where, they really encourage centers to take a look at their local context and really define what's excessive for them, with some suggestions such as looking at your callback rate, and when it's really high, like you go into the hospital often on call, they say, for instance, when your callback rate is greater than 50%, which would mean that every other call you're coming back to the hospital at night, the most call you should do is 1 in 7. And take a look at your own schedule. Does this align with that or not? And I think the other thing to think about that is really important and is really absent from this article is it's great to say all these things. And just because I agree with most of it, that's good for me. But if you're in a community of 2 surgeons and there's no other surgeons around for, 200 kilometers, how are you going to do 1 in 3 calls?
Can I take a step back for a second, before we dive into some of the specifics? Do you think it's surprising that they tried to do this? Like, I have to say, I found it a little bit surprising that the American College of Surgeons would actually try to take a stab at defining this, because it's not clear to me exactly how they came up with this. Like, how did they actually come up with this idea of, like, or what their framework was for the recommendations that they put out? Again, I think a lot of what they're saying makes sense, But it seems also kind of ambitious for the American College of Surgeons to basically define what they think would be reasonable expectations across such a broad spectrum of different kinds of surgical intensities and disciplines and all that kind of stuff. Like, I don't know. What did you think about that?
Yeah, I think that's really important to acknowledge that this document is incredibly broad and surprisingly specific given how broad it is, which I think is what you were getting at. And my understanding, reading their discussion and some of what I think is coming from the American College is more specialty specific that take into account a lot of the things you were mentioning. Like, it's probably different for a colorectal surgeon in academic practice than it is for a colorectal surgeon in a community practice, which is different than a urologist, which is different than a vascular surgeon, which is different than a trauma surgeon, depending on where you practice trauma. So there's a lot of local nuances that I think it should not just be, applied carte blanche, but I think what it has done is generated a lot of discussion that is positive and has surgeons thinking about how much they work and why, and really reevaluating, I think, that perspective that we're kind of wired to do the right thing and fill all the holes in kind of regardless. And we think that's right for our patients, for society. And, if you read the first half of this article, I think they point out why that's not right for us, both in terms of our own health. If you saw a recent JAMA surgery article that said surgeons actually die more at a higher rate than non-surgeons in the profession. And I think recognizing that at our current pace and the way surgery is in 2026, there's a real sustainability problem. And we have to think about how we're going to sustain our workforce. Because if you don't have a healthy workforce, you can cover as much as you want, but it's going to eventually lead to differential patient outcomes. And we probably already see that in a way. And when I go talk about this with other departments, we all make choices, both as surgeons, divisions, hospital, society. For instance, let's discuss how quickly, if a patient presents and gets referred for biliary colic, how quickly should that patient be seen by a general surgeon? Once they're seen by a general surgeon, how quickly should that patient get an operating room? Because that real goal, like taking a huge step back and saying, what is the care we want to provide for our community of patients as surgeons? That really informs how many surgeons you need and what infrastructure is needed to achieve those goals. I think cancer care, to your domain, has some guidelines on what the expectations are, and that's fantastic. And I suspect that a lot of the shuffling that happens in OR schedules tries to meet those. But it's a choice, because that's at a detriment to someone with, on the face of it, less important disease.
Yeah, that's basically what we've said, is that these types of patients, that you're right, exactly right, that we have to make choices, and we have, basically, by saying, if you don't have cancer, then you can wait for 8 months or a year to have your colovesicular, colovaginal fistula dealt with, right? I remember we talked about that in the previous episode that you came on. So I think to me that this document from the American College of Surgeons was really more so than even setting the specific standards out, but in a way it was sort of like a position statement, right? Or like a message being sent that we think that something needs to be done about this, and that we need to start thinking about defining some of these problems, and how we make the choices that we make, because not making a choice is also a choice.
That's right. And I think what you've arrived at with respect to cancer care, the choice for everyone else just wasn't made. It's just a reflection of a choice that was made for patients with clearly urgent need for care at, maybe the detriment of other patients who can wait. And I think we all have to appreciate that there isn't unlimited funding either. And so this is, getting to the facts, and again, noticeably absent, probably intentionally from this document, is, well, how is all this funded then? If you say surgeons should be compensated for a quote unquote excess call and figure out what that is, where does that money come from, and who is going to pay for that? I suspect, if somewhat, again, Canadian example, hawk money, honorarium on call compensation, that's kind of getting to some of this. Like that, I think that actually is pretty thoughtful, where it recognizes that often productivity doesn't really compensate you for all the things you gave up to be on call, or those things that might make your night challenging, like a phone call at 10:30, 12, 2:30, 4, where you generated, maybe no billable thing, but you were up all night doing patient care. And I think hawk money is meant to account for that. Whether it does accurately, I think, is another discussion probably that is had at many places around the country.
So let's dive into some of these recommendations. I think they're interesting. So the first one you picked up on was that on page 8 was that callback rate. And if they have these suggestions, like you said, less than 1 in 3, callback rate 10%, less than 10%, 1 in 4 if the callback rate is 10 to 25%, equal to or less than 1 in 5 if the callback rate is 25 to 50%, and less than 1 in 7 when callback rate is more than 50%. And then they have a formula there, right? For how you should compensate people for excess call. What were your thoughts as someone who's like really looked into this and done kind of a survey of what actually happens at trauma centers? Like, do you think that this is actually sustainable, or is this just sort of pie in the sky? Like you said, like if you're a community hospital and there's no one else to cover, like there's a community hospital near Kingston where there was one surgeon who'd been working there for his entire career. One surgeon. Now, granted, he could send things out he would take every other weekend off, or week off, and on those days we would get those, we would have to absorb those patients. But like for the rest of the 50% of the time, he was on. So I don't know. Like, again, it sounds nice, and I think those numbers are reasonable. They sound reasonable to me, but I don't know if that's even realistic or feasible.
I think you're asking all the right questions. And, to that specific surgeon's example, I think there's many ways you might frame that. So if you say, if that person wants to do that call and is okay with it lifestyle wise, then how should they be compensated in excess of these quote unquote norms? And I think importantly, in the Canadian system, when the payer is society, there's some really interesting things that can happen, because how much does it cost to transfer a patient from that hospital to Kingston? Do you just ballpark it?
Yeah, hard to know. Like the ambulance ride, that getting assessed and emerge again, it must be thousands of dollars at least, probably more than that.
Right. And so is there a world where surgeons, that surgeon included, if they're doing a service by preventing patients from being transferred out by doing an excessive call, maybe they should have a share of that compensation to prevent money spent elsewhere? It seems like a win-win to me. Or maybe, I think there's some worth exploring, like, okay, you guys are close. Do you want to go bring the surgeon to the hospital, like basically an internal locum, where they're going to get, a good surgeon. They're going to keep patients in their community. They're going to avoid that transfer cost, and it's still going to be cheaper than transferring them by paying you on-call compensation. And it has all the fringe benefits of the patient staying close to their support system. Their family might not be able to afford to travel to Kingston to see them. They, might have a dog at home. Like, there's all these other fringe things that are related to this concept of on-call work, which I think is, crosses all subspecialty boundaries, which is why it's really important to talk about. And, other groups, and they kind of highlight them here, I think have done this well. Other groups here, and they highlight them in the paper, I think have really done this well. And I don't really want to get into a discussion about shift work because it often brings up a lot of feelings and emotions. But, emergency medicine, they went through this. They've done this. They know what a full-time job is in shifts, and they often get compensated when they work over that, just not on a productivity basis, but on a time per hour basis, like hourly rate. They just get compensated for it. And that model, there's no reason that shouldn't work in surgery for call as well.
It's funny. It's true when you talk about that, like comparing us to emergency medicine, it stirs up feelings in me.
I know it does.
It totally does.
No, it does.
I think it's partly because, we're not exactly the same as emergency medicine. Most of us, I would say, we're not, unless you're at a really busy level 1 call trauma center like you, most of us are not staying up all night, every night on call. So there's this perception, at least, that, oh, it's fine that we can work the next day, whatever. We've been trained to do this. We've been enculturated to do this. And then the sheer impracticality of having like hiring enough surgeons just to cover call. Having said that, there's so many places now that are expanding their workforce coverage to have at least a few dedicated acute care trauma surgeons, mainly to cover call. So, whether we admit this to ourselves or not, I think we are having to acknowledge that people do not want to be on call.
I suspect so. I guess you have to delve into maybe why they say that. And it's very likely multifactorial. One is probably they aren't compensated well for being on call, specifically when the call doesn't involve operating. They're just not compensated well for their time. So yeah, I probably wouldn't want to do it either. Two, it's, very disruptive for their other planned activities. And, back to that, professional altruism. In what world are you going to cancel a right hemi the next morning for cancer if you've been up all night doing, emergency general surgery, taking good care of patients, but then, the model's not set up for you to have a built-in rest for call because call's unpredictable and you'd rather suffer through in the event that it's busy rather than cancel the next day, build in a rest period, and you slept all night the night before, and lucky me, I'm off the next day, because you're also losing out on income there. Like, the incentives are all misaligned. And often, well, you know what the incentive is. The incentive is to work more and sacrifice your own health and your time with family, et cetera, to take care of patients. That's exactly what we're talking about. That's the incentive.
Yeah, we can talk about this more. It's funny because we have this group chat with the other chief residents. Everybody has this, right? So the other chief residents that graduated the same year as me, and we often talk about this idea that, like, is there something different about our generation or the generation after us, the quote unquote millennials? Like, do we just not want to work as hard as before? Like, is that why now the American College of Surgeons can put out a paper as with these kinds of statements? Or are we losing some of our quote unquote professionalism? Do we not see our profession as a vocation anymore? Like, I wonder these things, especially when you talk to senior surgeons who really do seem to think that there's a difference in our quote unquote work ethic.
Yeah, I think every generation says that about every other generation after them. back in my day. And, there's a few kind of comments here. One, and it kind of, saying, back in my day, I'm like 6 years into practice now, and you're like looking at med students, and you're like, oh, no one wants to work anymore. They said the same thing about me because, we only did 1 in 4 call instead of 1 in 2 call. And no one wants to work anymore. I kind of view it as the pendulum swinging to healthy boundaries, and almost necessarily it's going to swing too far because you have to. If you don't swing far enough, you're not going to arrive at the sweet spot, because then you're going to keep, you're going to keep away from that sweet spot if you don't swing hard enough, I think. And so I think this is meant to almost get out ahead of it, in that it at least provides a framework of what's reasonable. Whether you should adopt these carte blanche, I don't think you should. This should generate a discussion locally about why we work the way we do. And we're all human. I know we're all trained, we think we're different. We all have the same circadian rhythm that hits us at 2 a.m. Like, we all need sleep, and being up all night and operating the next day, or even, doing clinic the next day. Yes, that seems like very patient-centered at first thought. But the reality is if you said, hey, Amir, you're going to be on call for general surgery, and when you're post-call, I don't want you to do much clinical work. And I recognize that is lost income for you in the model that we've set up. So I'm going to pay you a couple $1,000s to be on call. You'd probably cancel your next day. You wouldn't cancel it. You wouldn't even schedule it. And then you then have a need for more surgeons to do that daytime work that you were just sacrificing yourself for. And now you have more people to do call too. This is great. This is a win-win-win. Who's going to pay for it?
Yeah, well, I think there's some other things that I want to discuss in this paper, but I think one thing that we might have to accept is maybe we get paid less.
This comes up regularly, actually. And, it all comes back to the, tale as old as time. It's time or money. And if you want to make more money in a fee-for-service kind of eat what you kill model, you're sacrificing time by and large, whether that's on-call time, daytime, weekends, whatever. And if that's really the way to make more money in that kind of model. In a more holistic employed model, which I think is somewhat germane to what's happening at many places across the country, is, how many surgeons do we need to hire at our hospital to take high quality care of the patients who need surgery, electively and emergently? That's the question that we should try to answer. And then we can say, well, okay, then we'll deal with the compensation after we've answered that question. And that might mean that you make less money and you have more time, or you live longer. These are things worth discussing, and either's probably fine, but I think prior to this document, these discussions were kind of had in back alleys or WhatsApp group chats, and now at least they're at least more open and transparent, so we can at least be conscious of the choices that's made by ourselves and our leadership. One thing that's really important when we're talking about stuff like this is surgical leadership, because if you're moving away from fee for service to time-based things, you need to make sure everyone's a good actor, because again, the incentives change. You're no longer incentivized to do more operations. I suspect, if any family medicine doctors are listening to this, they understand that.
All right, well, let's look at some of the other things on here. So we kind of started the discussion a little bit before we started recording about the other recommendation here, which is that surgeons have two full OR block days per week. So basically 2 OR days a week. That seems like an American thing. Like, I don't I don't know that there's a lot of Canadian surgeons necessarily that have 2 OR days a week. Like we have an OR. For example, I have an OR day and an endoscopy day a week. I guess maybe that would fit into that.
Yeah.
That's kind of amazing that they would make this as a target.
And
I find that actually kind of interesting. Like, I wonder, is this just simply because of the RVUs and the predominance of that? Like, why did they feel the need to
I
set that out?
I suspect that's there's a few ways you might look at that. One is, I think, the either implicit or explicit choice that patients don't wait as long for surgery here, and you necessarily need more access to OR time to achieve that differential wait time. And so if you look at a typical surgeon's week, like what should it look like? Okay, let's look at Monday through Friday. So 2 of those are OR days. One of those days is clinic. And so then that begs the question, to fill 2 OR days a week, how much clinic do you need? I think that's an unanswered question for most specialties. It's a good one to think about, and you might be able to figure out your own, looking at how far you're booking out, etc. But so there's 3 days taken up. So what should go in the rest of the days? Like call. How do you want to treat weekends? Someone's got to work. So if I work Saturday, Sunday, is my weekend then Monday, Tuesday? It's something to talk about. Like, I think what call often happens is it's like the extra. Let's think of what a Monday through Friday looks like. Cool. And then we'll just throw some call on there and, figure out the rest later. But the reality is that's like a really unfortunate way to look at a full-time job. Like, you have to account for it somehow and come up with what's reasonable.
It is interesting when you start slicing and dicing all these different pieces out. And I think that's one of the best things about this paper or this article is that it starts forcing you to start thinking about how people spend their time and all the other ancillary things that go into how you use your time, like exactly what you said. And I've only met a very few surgeons can articulate how many clinics they need to do to fill their OR day, and that varies wildly. And
Yeah.
sometimes in an actually kind of unequitable way. Like for example, in the colorectal world, you might do if you're interested in like pelvic floor disorders like rectal prolapse, things like that, you might have to do like 5 clinic days to fill a list. Whereas if you do all cancers, then you might just need one.
Right. Notably, those pay different, and this is why I've somewhat changed my perspective on employment of surgeons, because I think historically it's viewed poorly, like you don't want someone telling you what to do. But if you look at it holistically, from your group of colorectal surgeons, you're tasked with taking care of that cohort of patients. They have rectal prolapse too. They don't all have cancer. And so in your group, do you believe that the people who are taking care of that non-cancer disease should make less than you? Like, is it less hard?
Well, exactly. It's actually more complex sometimes, right?
Right. And so as a group, I think you should say, maybe we want to take care of this group of patients. I don't want to take care of them, but you do. So why don't we almost take some of my income and give it to you so I don't have to do that thing I don't want to do, but think it's really important from our community?
I hope no one accuses us of being communists after that.
I was more thinking socialist, because that's what it is.
Yeah.
Yeah, it's taking a big step back and saying, what care do, like, because the fee for service model is very siloed. Like, your incentives are for you, the surgeon, and the patient in front of you. It's not for, hold on, it's not just about the patient in front of me. It's London, Ontario. What are their surgical needs? So let's take a big step back, and who's good at this area of surgery? Who wants to do that area of surgery and is good at? They all pay differently, but we could probably come up with some, rationale. And I appreciate there's lots of history here around relativity.
as usual, provocative discussion, and I'm really glad we had the chance to sit down and talk about it. If there was one takeaway that you thought people should walk away from after kind of listening to our discussion or reading this article, what do you think the takeaway should be?
My takeaway is if you're a surgeon, look at your last calendar year, 2025, and try to count up a few things. And this should be somewhat easy. Maybe it'll take you a half hour. How much did you work? And you can frame that however you want. How many days did I go to the hospital? How many nights I was on call? You can get as granular as you want. But I would say, like, how many weekdays did I work? How many weeknights did I work? And how many weekends did I work? And just look at that number and say, does that feel right for me? Or why did I work that much or little, as it were? And at least you have an idea, a starting point for you. You know yourself more than anyone. Is that right? And if it's not right, maybe you got to work more because you're like, man, I didn't operate enough last year or whatever, Or maybe it's like, oh man, I did a lot of weekends of call last year. That seems like a little much. And what's normal? And then go start looking and asking around and, ask other people how much they work and why.
Provocative. For me, the biggest takeaway is simply that I think we need to make a lot of our underlying assumptions and underlying expectations more explicit. And I think that this was a good start in trying to do that. Like, if we expect people, like, fine, you expect people to work post-call, no problem. But then I think that we should just be explicit about that and what the implications of that.
Yeah, that's a choice.
It's a choice. And I think we just need to be much more explicit about our choices, and maybe not even necessarily attach at the certainly at this period of time when we seem to be in this sort of generational shift where we're trying to define these things. Maybe we don't attach a value statement to those choices. What simply just declare those statements as they are and declare those choices as they are and work from there and decide, and collect the data and do the math. And I love how when we last had this discussion, you talked about this Excel sheet that you have where you basically track everything that you do, right? I love that idea. I've been really, and I sent you, so after that discussion, I sent you this book that I
read it.
Read. Yeah. Did you? So I sent Pat this book by Cal Newport called Slow Productivity.
Oh, I read the other one.
Oh, you read Deep Work? Deep Work, right?
Deep Work, yeah.
Yeah. So Cal Newport is this computer scientist, and I think if listeners may be sick of me saying his name after a period of time because I got really into his stuff, but his basic shtick is this idea that people don't really do deep work, which he defines as something that is intentional, effortful, and instead spend their time doing all this other nonsensical stuff, right? Like answering emails. Like the average office worker sends like 100 emails a day, something ridiculous like that, and then spends the rest of the time on meetings. So they don't do any deep work. But it was interesting for me reading that book, and I'm curious to hear your thoughts as we close this out. I was thinking about this idea of like, do we as surgeons do deep work? And I was thinking, oh man, the operating room is like absolutely like the purest example of deep work, right? It's effortful, you're defined. Like we can ignore phone calls and be like, yeah, I'm operating. Like, it's that flow state sometimes, not always, but often you can, if you're really into it and things are going well, you can find this sort of flow state. It's the ultimate deep work. But then I was thinking about like all the other stuff that we do. And that for sure is not, there's many aspects of what we do that is absolutely not deep work. Certainly the administrative stuff, spending all this time on computer EMRs, ordering stuff, that is not. But anyways, even moving aside from that, like to me, I was thinking that we have to be so much more explicit, and we need to teach surgeons when they're going out into practice to be a lot more intentional about how they use their time. Otherwise, it's so easy to just be like, oh yeah, this is what surgeons do in our center. This is how they spend their time. Like, you're talking about surgeons have, if you have 2 OR days and you have, let's say, 1 or 2 clinic days, what do you do with that other 1 or 2 days, right? Total open question. But if you don't define what that, to me, especially after reading these books, I thought, if you don't define for yourself what those days are going to be spent doing, you will do whatever someone asks you to do. Basically, you will fill your time with something, but it may not be something that really matters to you or even advances your career.
Specifically, that bit about being in the OR as deep work was exactly what I thought as well. And the book almost made me feel guilty because like it really resonated, all that, idea behind the kind of superficial nature of like what takes up most of your day outside of operating was like, oh man, that's a lot of time that I could learn another language, or like, I could really accomplish something. And, somewhat relevant to all this is, the whole concept of protected time, which is not, probably the right venue currently, but a great discussion for another day, is like trying to get people back doing deep work so we can advance is just a great goal.
Yeah, I couldn't agree with you more. And just to be clear, like I think like some of the other things that we do, for example, even clinic, is very valuable. I don't know if I would call it deep work in the way Cal Newport defines it, where it's like really effortful, intense work in that way. But it is effortful work. You're certainly engaged, and it's obviously meaningful, right? In that you're seeing patients, you're meeting with them, like that's. But like a lot of the other things that we do,
Yeah,
it may or may not be helpful. I think that the point is, I mean, we don't necessarily need to decide right now what's meaningful or not. And meetings, for example, if you're in administration and stuff, that may be important, right? But my point was that I think, especially on the topic of the article that we're reading today, it's this idea that we could just be much more intentional about how we spend our time. And I think as surgeons, we don't perhaps do that as much, and we just need to be much more intentional about it. And that doesn't necessarily mean that we should be spending every minute of our day. If we're not in the operating room, we're not doing research, that time is wasted. No, I actually think that that's the opposite message of what I hope people take away from our discussion today. I think we could just be much more intentional about what we do
and be bored.
And have healthier lives because of it.
Yeah.
And actually get more out of our life too.
Yeah. Aren't you upset that airplanes have Wi-Fi now? Because I think when I was reading the book, I was like, that's like the perfect deep work opportunity, because there are no ability, previously to have, before TV screens and Wi-Fi was on airplane, you're like, what am I going to do? I'm going to be bored or do something more meaningful,
Yeah. Well, anyways, thanks so much again, Pat. I know you're on call, and so carving out some time for us, I really, really appreciate it. And I really look forward to the discussion. And I hope listeners will send us and Pat an email. You can reach the podcast at podcast.cjs@gmail.com. And we'll put Dr. Murphy's Twitter handle in the show notes as well, so you can harass him with how you hate the term shift work.
Yeah, and if you're really ambitious, send in how much you work and how many operations you do in a year. 2025.
I love it.
Yeah,
I love it. You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.